Welcome to today's episode. I'm Rolf Taylor, producer for this podcast series. And we're at the National Medical Association Annual Assembly, and I'm joined by Dr. Lisa Merritt, who, like my co-host, Dr. Randall Morgan, is based in Sarasota, Florida. So it's great to have you here. Thanks for joining us, Dr. Merritt.
Well, it is my absolute pleasure. Thank you for having me.
And here's a little background about Dr. Merritt for our listeners, who's in fact the first, now am I saying this correctly, Physiatrist?
Well, that is one version of the pronunciation, and you did it beautifully. The other one is physiatrist.
Physiatrist sounds a little more American.
Precisely.
Okay. So Dr. Merritt is the first physiatrist to join us on the podcast, and more about that specialty a little bit later. Dr. Merritt is the founder and executive director of the Multicultural Health Institute, which since 1995 has been targeting health inequities, their effect on our nation's citizens, and the positive economic impact of health education, nutrition, and maintaining a healthy lifestyle. The essence of the Institute's work embodies principles of service, empowerment, and collective community effort. It's a beautiful description.
Thank you.
And a graduate of Georgetown and Howard Universities, and we've already had several Howard University alumni in today's session going out on the podcast. Dr. Merritt trained in family and community medicine at University of California, San Francisco, and completed her residency in physical medicine and rehabilitation at Baylor College of Medicine in Houston. And she's written extensively about multicultural health issues, physical medicine, rehabilitation, and integrative medicine. Did I miss anything?
Oh, there's a few more things in between, but that's enough to start with.
So we had Dr. Wayne Frederick first thing this morning.
Oh, my God.
So it's a very Howard morning.
That's right. My fearless leader. He is one of my heroes. I was so proud of him last night. I can't believe they just finally gave him a recognition that he should have long been receiving.
He did a really lovely interview.
I'm
really
sure.
Just great.
He's a lovely man. He's so real. Yeah. He's
so. And who else? We had Dr. Hood as well.
Another one of my mentors.
Really?
Yeah.
Okay.
Because when I was in California and I was with the Golden State Medical Association, I was vice president, and he was out there. I was in Sacramento and he was in San Diego, and we did a lot of stuff.
And you have a multicultural institute,
mm-hmm.
and he has a multicultural foundation.
Right.
So have you been cross-fertilizing?
Well, more in sense of working in parallel, because I started it out there, but then I moved it back east when I moved back to Atlanta, and then down to Florida with my parents. So, everyone's work has been sort of this universal consciousness of working in synchrony of similar things without even necessarily talking about it. That's the beauty of this work.
That's brilliant.
It
love
is.
That.
Yeah. Exactly. And in Dr. Hood and I, we speak pretty much every year at the meetings. And then he had an aunt that lived in Sarasota that he would come to visit. So we had our own ongoing connection and talking and advising. And his was a different setup because he had it as part of a large federally qualified health system. So he had good funding and he was able to design an entire system, which was fantastic. And my other mentor, Dr. Robert Austin, who recently passed in Houston, also designed an amazing system of care for these he coined the phrase children's medical home, the whole idea of wraparound services and all of this stuff. And he was also my mentor from residency. So the beautiful things about what happens in these environments, in these organizations where we're cultivating leadership, is we work by example to show the ones coming behind how to do what they want to do, and to encourage them to do this work.
So when we were scheduling this interview, I think you were emailing me from Ghana to say you were going to be kind of late arriving back to the conference, and we had to make the schedule work. I think you got back a couple of days ago, and now you're here at the NMA convention. So how were your travels, and what took you to Ghana?
Oh, it was wonderful. There's a saying in Ghana, they have a system symbols that have meanings called Adinkra symbols. It's kind of like hieroglyphics. And there's one symbol many are familiar with called the Sankofa bird. And it's a bird that's looking back as it's moving forward. And it's the whole idea of sometimes we have to go back to our roots in a sense so that we can move forward. I first went to Ghana in 1981 before I started medical school as part of Operation Crossroads. And it was founded by Leon Sullivan with some others who began the Peace Corps, which started in Ghana. My aunt originally was very close friends with many of the leadership in Ghana, and when she worked at Yale Divinity School in the late 50s and was there in the early 60s around the whole independence movement. My parents went in the 70s, and my mother, being an artist, had done some work. So this trip was me going full circle with an educational tour, as well as revisiting my sort of community health, public and international health roots when I did some hands-on work there that really changed and transformed me, as well as to bring my mother's artwork back around full circle and talking with some people over there, including Kwa Ansa, who's got the Bisa Aberwa Museum on Pan-African history in Sekondi, and he's also the head of TV Africa. And visiting with my friends from Operation Crossroads from 40 years ago when we were young people, and all who've gone on to be amazing leaders in their own right, doctors, business people, heads of schools, things like that. And really celebrating that foundational type experience really can transform young people, which was the vision of Leon Sullivan. And that cross-cultural exchange really can help breed greater understanding and collective work that's impactful.
Tell me a little bit about Operation Crossroads. How was that convened?
So Operation Crossroads Africa is a summer, shorter version of the Peace Corps concept. So it engages generally college students who want to do something meaningful in their summer. They raise money and they go with a team to places designated by the Operation Crossroads team to work in concert with local communities on projects that they have needs for. We did a mission trip on health and education, and even building a school, and even digging a latrine, and even doing health education at the time, and cultural exchange. When I came back, I had malaria, and our entire team had malaria, and we actually changed the recommendations for prophylaxis for malaria from the CDC for West Africa because that's when resisting strains were starting to come. But because of that somewhat notoriety, as we should say, everyone at Howard Medical School came to know who I was because I was the medical student that had malaria. And this was at a time when HIV was coming into being, but we didn't know what it was yet. And they put me in isolation, and they didn't know if I had this new terrible wasting thing. My blood was all out of whack, etc. And eventually they came to figure out that I actually had malaria. But my attitude was like the Africans from what I had observed because it was so endemic, and they really treated it like we treat having the flu. But they have a lot of traditional remedies, which was the other part of the return trip at this time. My uncle has a farm, an herbal farm that's also part of an herbal traditional medicine research facility. And they're doing amazing things with a lot of conditions there, including malaria. And it's part of why they didn't have as much decimation from COVID because they use their traditional remedies. And the people are, in general, stronger, more resilient mentally and physically. And they eat a very high antioxidant-rich, high-fiber diet, which is part of the nexus of our nutritional awareness, like going back to our original traditional diets, as well as physical activity, etc. So I had a chance to visit the herb farm, and I had a chance to utilize those things because some of the members of our group that I was traveling with, unfortunately, became ill, and we didn't have full access to all of the Western medications, etc. And it was incredibly impactful and empowering to see and learn and observe how some of these other remedies work so wonderfully and with few side effects.
So your uncle has a herb farm in Ghana.
Yes.
And those are not culinary herbs. Those are
Some of them are, but culinary herbs. But that's the whole beauty of it. It's like Caribbean too. A lot of the food we prepare, food is medicine. Mm-hmm. So the combination and the use of different herbs intentionally is including them for their other healing properties. For example, turmeric, which is a big component of curry, that is very much a staple of a lot of Caribbean dishes and Indian dishes, etc., is excellent for immunity, for anti-inflammatory, for arthritis, for pain management.
And I have to tell our listeners that you are right now wearing a turmeric-colored shirt and pants with matching hat. Looks absolutely splendid. I wish we were on video.
Thank you. Thank you. I saved it specifically for this, not knowing if this was live video or what.
Well, I'm afraid it is a little wasted, but I'm so glad I'm so glad you did.
Thanks.
And no, but it's interesting you should mention about the nutrition part. About 6 weeks ago, somebody convinced me to totally change my nutrition. So I switched to high fiber,
Yep.
high protein,
Yep.
mainly plant based,
Yeah.
with a few slips. And it's totally changed
How
my
do you feel?
entire way of thinking about food in about 6 weeks. Well, I feel like I wish I'd done it a long time ago,
Right.
number one.
Yes.
And I feel like it was such a difficult learning curve for about a month. And
Yes.
now I've kind of got the gist of it. But then I'm losing without really
Trying.
being hungry.
Right.
I'm losing between 2 and 3 pounds a week at the moment.
Yeah.
And I know it's early days, but I
Physiologically.
totally buy this.
Well, yeah, and all that fiber helps scrub out all those toxins and that cholesterol and all of those other things in your system. It's so beautiful when you begin to see that transition for people, that it becomes self-reinforcing. It's not so much the mind game of having to force a change, but to want to make the change because you see how much better you feel, and it begins to really make sense, and your body remembers how it should feel. We're so burdened by food that's full of so many preservatives and additives and artificial preparation. It's so far removed from actually being nutritious here in the
Right.
States. Even Europe is so much better. My daughter remarks how the milk, we just loved it. It was so real. I mean, and then we were riding on the trains through France, and the cows just looked so comfortable. They were just sort of hanging out like we're just being cows, none of this
Yep.
stress.
Yeah.
Yeah.
Happy cows.
Happy cows.
Yeah.
Make happy milk.
Yeah. My parents live in southwest France, and they go direct to the farm for their milk.
Right.
And it's just a lovely symbiotic kind of existence that they have. And they see the cows that give them the milk, and they know the cows are happy.
Yes.
It's a really nice situation. But I think I was lucky in having a doctor friend who just took the time to convince me to do these things.
Yes.
And something she mentioned was, with her patients, that it's such an enormous effort for her to convince patients to change their diet. And she doesn't have the time to do that with every patient. And she doesn't have the relationship where, she's texted me every other day to say, are you sticking with it? I'm interested to hear your thoughts on that in terms of that. That education or that getting that change with patients, it's hard work, right?
Well, that's the essence of why I started the Multicultural Health Institute almost 30 years ago, because I recognize that clinicians are busy. Some are not necessarily trained in those particular areas, and that even before the social media influence, that people tend to listen to people they know, or to a matriarch in a family, or to the minister, et cetera, so that if we could work to provide health education and information resources directly to people who are thought leaders in whatever way that happens, and in a way that's understandable and that people can embrace, that becomes self-reinforcing. And that was the reason why I began this. Originally, they were the gatekeepers of community health, and then they became the safekeepers of community health. And now we have community health navigators, and we are positioning to become a certifying agency for these different types of community health workers, specialized in understanding the cultural nuances dealing with diseases of, quote, disparity, which really are inequities, and dealing with the social determinants of health, including the environmental aspects of that. The fact that there are environmental influences that are going to impact all aspects of health, including the sourcing of food. So by teaching people in a peer-to-peer manner, and then also having the standardized education, like with the official CDC T2 diabetes prevention program for my church ladies and my grandmothers and my former sex workers and et cetera, that we have worked with over time, when HIV training, et cetera, having them then impart the information and create support groups, not to teach them a certain topic, but to teach them about feeling well. Do you want to feel well? And then helping to find the goals, and then setting the goals and working together each week and meeting and sharing recipes and encouraging one another, recognizing slip-ups, admitting their own difficulties as humans. Everyone's wherever they are in their process, keeping it human. We get more outcomes. When we did that in Atlanta as part of the REACH Collaborative, our group was actually recognized because they were able to measurably observe improvement in blood pressure, weight loss, more consistent adherence to exercise and dietary change. And that was focused on cardiovascular health. So we'd show information about cardiovascular stuff, but we'd have people do each other's nails, talk about their kids. I mean, it was like a visit, and it was run by peer educators. And that to me is the essence of our whole traditional way of life, that the women would come together in groups, share information. And that's what we did with Operation Crossroads. We worked with the Queen Mothers and the women in the village to talk about boiling the water to stop the chain of schistosomiasis and other transmissible diseases. And once they understood the concept of it, and they could explain to the others and then say, well, this is how this is going to go. And then that's what made the change. So you can have a couple people educated and you can impact thousands.
Right.
By propagating information exponentially.
Increasing numbers.
And now with social media, we're really working with it that way. It's been wonderful. Like just a couple weeks ago, our lifestyle educator, Darlene, who's a very sweet lady, not any super professional degrees, but a good heart person. Her live broadcast, I think, has already been shared like 2,300 times.
Wow. Okay, so
I couldn't see that many people in a year,
So just to clarify, when you said we, you mean the Multicultural Health Institute in Sarasota.
Yes.
And the certification is that you can now run educational sessions, and people are receiving certification from that, and that changes the way that they can educate the community.
Well, no, there's actually a certifying process for community health workers in the state of Florida. So we're working to become a certifying agency.
Right.
Because right now, the agencies that are certified to certify health workers don't know as much as we do about doing community health work. But they're the ones certified to certify people who are paying a lot of money, which is hilarious to me.
So they're doing the certification, but they're not doing it in a multicultural way.
Correct. And there's also not enough multicultural people being certified because some of the standards that are required for that are too high. Like when we did our HIV/AIDS outreach, we trained about 25 community health workers called the Gatekeepers of Community Health from all different kinds of backgrounds. And we were told by the health department, well, they're going to have to pass a test. And we know it has to be at this time. And I said, well, they're working. We need to change the classes, make them in the evening and on Saturday. So I had to negotiate that to get them through the certification. Everybody passed the test fine. They were so much more effective in getting people to take testing, if they tested positive, to get them into treatment, to stay into treatment, to stop the propagation through the use of universal precautions, et cetera. One year we gave out like 100,000 condoms in 100 days, just community-wide protection. I mean, they were an army. They were about it. But until we started that work, there was no educational efforts targeting the African American community, which was 5% of the local population, but 30% of the caseload of AIDS.
Wow.
So that's just an example of the power of that model and how it can transform a community.
And then you can really find the hot spots.
Exactly. We flattened that whole curve. The percent positivity and the escalation ever since we started that effort flattened right out.
So a big focus of your work is understanding and reducing disparities in chronic disabling conditions. So could you give some examples of the conditions that you're really prioritizing? And what are the kind of related disparities? Could you share a kind of overview of that for our listeners?
Certainly. Well, first, I would like to start with our work, which is considered community-based participatory research. The essence of it begins with community assessment. I may know statistics. I may know the epidemiological challenges of an area, which I do. However, the community has its own perspective on what it's concerned about and what is important. So we began our work with a community assessment on what were their main areas of concern, what did they see the needs were. And every year we would work together towards that. And then every about 3 to 4 years, we would do another assessment to see how are we doing, what else we want to focus on. The initial concern was about walkability and safety and sexually transmitted disorders. So that's why we focused on HIV, et cetera, which can become a chronic disabling condition. In my mind, I always knew diabetes was a huge issue. We came to terms on diabetes, and we decided with diabetes being the focus, the approach to that would also help deal with cardiovascular disease, cancer prevention, mental health, and these other issues, because diabetes is all about exercise, number one, activity, and then, of course, dietary changes, and then understanding the proper screening and self-monitoring, the signs and symptoms, and getting access to care. Chronic conditions that we see usually are a result of complications of diabetes. So we're going to have increased rates of stroke, increased rates of kidney disease, increased rates of heart attacks and heart disease, problems with vision, increased rates of visual impairment, problems with peripheral neuropathy, chronic pain, increased falls, etc. The other chronic conditions that we often see are musculoskeletal. So I know you're with Movement of Life. We did a great program together a few years ago, and arthritis, and again, as a result of often diabetes and cardiovascular problems, increased rate of amputations. So as a physiatrist, I'm the one that helps rehabilitate those people and prescribe the prosthesis, etc. Preventing that and saving people's legs has been a major part of our work. Identifying where they are headed and getting them to change and getting the right evaluations, getting the right revascularization and things like that, which are actually more expensive. And there's an angle with the insurance companies, we will say, where it actually is more economical to do an amputation than to try to salvage a limb, just to put it plainly.
Yeah, yeah. And that's just brutal and awful. And
that's why they have a whole seminar this morning on that. Yeah, it's just horrific.
Yeah.
So, yeah, those chronic conditions, the other thing is when you talk about stroke, which is a big thing in rehab, inpatient rehab caseload, the African American Latinx patients are far more younger, Native American as well, than the white patients because they tend to have their bodies have already been under demands of high rates of diabetes, not controlled, high blood pressure, not controlled, general stress, access to nutritional food sources is more limited, access to real care and aggressiveness of care is not as, and surveillance is just not the same. We have to really advocate through the care navigation program.
Yeah.
We have people coming out of the hospital and then they have no follow-up care, or they can't get an appointment for 3 months.
So it means you really kind of, if the disparity is so great in terms of age of onset, then you need to have a different way to think about screening.
Right.
Because the generic numbers in terms of what age do you screen at are not applicable.
Right. With prostate cancer, breast cancer, that's a perfect example. Much higher rates in Black people. And often we can follow family lines. In our area, we have family lines with women as young in their 20s and 30s with breast cancer. And the starting point for breast screening is like 40 for some insurance. So that's too late. So we did a whole thing where we trained people on how to do self-exam, men and women, because often it's the men that find the lump in the women. So we train them on how to do the assessment, how to check the breast, what the signs and symptoms are, where to get help. And the biggest challenge was women, and not so much men, but men can get breast cancer, but people who were hesitant about examining themselves because they were hesitant about finding something because they had no way to know what they would do if they did. So we had it linked to breast and cervical cancer treatment program. So when the insurance said in our program, if they found something, we would get them to care, get them biopsied, and get them taken care of. And then that way we screened like 2,000 women. And we were able to identify those at highest need to get screening, to optimize the use of limited resources. And then of that, we found some positive cases. And I think it was like about 3 that we caught early, as opposed to when they finally show up in the ER with a giant baseball-sized mass that's all over their body at that point. So by doing that, we really helped improve outcomes, and we also helped reduce costs. And, unfortunately, that program didn't get funded again.
When did that end?
That was several years ago. Life pre-pandemic, post-pandemic.
Yeah.
Yeah, that was several years ago.
And was the end of funding related to COVID?
No.
Or is it just one of those unpredictable cyclic things that is just, it's hard for...
You do everything well, you exceed the expected outcomes, you deliver, but that was that, and then it was over.
You're the physiatrist perspective.
Yes.
How is your perspective of living with or rehabilitating from chronic conditions different from a physician? Can you kind of draw a distinction for our listeners a little bit?
I love that you asked this question, Rolf, because it is a definite, distinct philosophy that, first of all, we know rehab takes time, and we are the eternal optimists amongst all medical specialties. Because we get to work with patients with complex conditions across every body system, across every age range, we have a far better perspective and understanding of the potential and the incredible resilience of the human body and spirit. Whereas many other clinicians, not to their fault, but because they have a limited, say, the trauma surgeon, the trauma team, where they just get somebody that's just been mauled by, ejected from a truck and down the side of a road, all types of catastrophic care, which is what I take care of: traumatic brain injury, spinal cord injury, amputations, polytrauma. And they put the person back together, and they don't know if they're going to live or die, but they did their part. And the person may be behavioral, maybe all kinds of things going on. They don't necessarily always get to see what I get to see when they wake up, when we work with the family, when they work with the therapies, when they learn how to talk again and walk again and manage control of their bowel and bladder again, get their pain under control, their bones knit, their bodies realign, they regain their strength, they can eat again, and often sometimes go back to work. It's so incredibly rewarding. What I also find is there is an impatience of youth now. The younger clinicians are not being trained to really use clinical skills and listen and hear patients. The focus is on so much efficiencies because of the medical industrial complex effect. And they don't see with their eyes the way I, as a seasoned clinician, can walk in a room and just what I see and smell and experience of my interaction with the patient is very different. And the patient senses my attention level. They may open up more. At Howard University, we were taught something like 80% or more of the diagnosis lies in the history that you obtain from the patient. So when all of this information is being elicited by all these different intake people and forms and portals, you've lost the nuance. Patients may not even be willing to share certain things or remember, or if it's not being asked in a certain way, to allow them to tell their story. What happened to you? That's the first thing you had. What happened to you? And just in a way that allows them space to know this person's really going to listen. I've made more diagnoses and figured out more things for people who have been to see 3, 4, 5, or even more doctors. In general, people see at least 5 or more doctors before they end up with us. And we sit and we figure it out. We also help maintain continuity amongst these different specialties and other types of care providers who may not know all of what's going on with the patient, especially the geriatric patients. I live in Sarasota, Florida, and the work there. You may have a person that has 5 or 6 or more doctors as their regular providers. They have a heart doctor, they have an internal medicine doctor, they have a stomach doctor, and they have an eye doctor. All of these doctors are prescribing different things, not necessarily communicating with one another.
Right.
Yeah.
Siloed care.
That's right.
Could you give an example of a situation where you diagnosed a patient that the other doctors had missed? What mentioning no names, but can you just, like, what kind of condition is being missed until your approach is revealing it?
Okay. Here's a case. There's so many. This one was particularly fascinating to me, how off kilter there's a couple. One was, I had a lady who had brain surgery. She had a brain tumor and had been through a major medical center, had come to rehab. And we were going to strengthen her so that she would be able to begin chemo. So first of all, there was explanation, understanding, and fighting with the insurance company that it was worthwhile to do rehab on a cancer patient, which it is. And we indeed did help her to get stronger, to eat better, to have the family trained, and to deal with the whole, onset of the diagnosis. But at the time of her presentation, when I evaluated her, I detected that she had some type of a device in her chest. Was it a pacemaker? Was it I didn't know what it was. She had gone through this entire other procedure at this entire other facility, and nobody had documented that she had a device. I had to go through and insist on getting old records and track through things to figure out that she had actually been seen at a different cardiology group who had discharged her from care for lack of follow-up, probably related to the fact that she was having cognitive issues because she had a tumor in her brain, and that she was deemed non-compliant and refused back for care. She had a monitor in that was supposed to be only in for like a couple months at a time that was 4 years old.
How dangerous is that?
Well, and also a potential nidus of infection in somebody with cancer who was being treated for an infection as part of her post-op complications. Not to worry. I was like, well, good. We can see. And plus, she was having heart symptoms. So I'm trying to figure out what's going on with this lady. And how long had they been happening? Were they new? Were they old, et cetera? Well, we sorted her all out. The battery was dead on the device. Fortunately, it wasn't causing any problems. We set it up for that to get removed. We also set it up that the other treatment that she was supposed to be in and the levels of medicines that had been from the other place hadn't been followed up in the transfer of care. So a lot of it is investigative reporting and the continuity of records from one system to another not being either transferred or read or sufficiently going back far enough in somebody who's complicated and having that desire to figure it out. So that was one case. Another case was a gentleman that came in with severe hip pain that they couldn't figure out why. And he also had, I don't remember, some other kind of orthopedic procedure or whatever. And he had a trachestoma. So he was not very intelligible. And they were treating him like really someone that was not intelligent. The man was very cognizant. And he had to work by putting his thumb over the stomach. And he would enunciate and vocalize. But it was really guttural and a little hard to understand. As it turned out, this was long old. It was nothing new. It was well stabilized from when he had had throat cancer. He also, as it turned out, had a previous lung cancer and had had a lung surgery. He also had had a previous other cancer. None of this was in his records. And he had also had some GI issues. And then while he was on service, he developed COVID in-house. And so I was having to treat him for COVID, and then I was having to really advocate on his behalf, because when you talk about the difference of opinions, where some of the younger physicians were feeling like, oh, well, we should just put him on comfort care. I was like, death is not imminent. Well, he has that trach, he's got cancer. And I said, no, that was like 5 years ago. He's been living with this trach. But nobody was communicating with him because it was difficult to communicate with him. And when the wife who wasn't there who could communicate on his behalf, they just had made certain assumptions about this man who was very cognizant and really wanted to, and he was in a lot of pain. And then I had to work to figure out, well, he's probably got metastatic disease. And we need to know if we have to try to radiate the bones, which is why he's having the pain, and the surgery didn't work. It's all of these things that come together in a complicated patient you have to weigh out. You have to start with wanting to care about the patient. And I'm seeing that more and more, especially in older patients who may not have a family advocate, that there's a bit of ageism where people just decide they wouldn't want to live like that. They project their feeling, not knowing that maybe someone has lived with something for many years and had quite a good quality of life, been very productive. And we need to allow and afford them that option should they decide that. Ethics and morals need to be more in training. I'm one of the area that I'm interested in biomedical ethics, because if you haven't had the clinical experience on some of these cases, you really don't have the perspective to give the consideration from the patient standpoint. I hope that answers your question. It was long, but
certainly it does. And I think, it's interesting, kind of brings us on to my next question, because talking about ethics and morals as needing to be more in training. And then also, I know you're really interested and concerned about the lack of enough of a pipeline of people of color who are going through the medical system. Could you talk a little bit about your concerns there?
Well, that brings up the whole point when you look at cultural competence. There's a whole study through Harvard, the IATA study, that looks at implicit bias and studying different groups of people and pairing images and responses and assumptions, et cetera. The least biased group when it comes to physicians are Black women, because we're only 1% of all doctors. We need more, just in general. But because of our lived experiences as women previously, now it's not so bad, male-dominated field, and then as people of color, and what we deal with as caregivers in our own families, in our own communities, we bring an understanding, a universal sense of acceptance, of non-judgmentalism that allows the door to be open to hear people and interact with them. We also bring a greater ability to handle different things with greater resilience. And when I talk about pipeline, I also talk about looking for young people who bring that spirit of serving community, really caring with compassion and excellence, and also having a certain strength, because it's a tough job. It's a very tough job. I have 4 students right now that I am actively working to encourage and counsel, and have written recommendations for 3 for medical school, 1 for PA school. Several of them I've worked with since middle school or younger. and they're all brilliant, and they're all beautiful, and they're all wonderful, and they're all female. And I don't only select women, but it just happened in this group. I have another one that I just wrote a recommendation for him that I've also worked with through high school, that he's taken a different path. But he's probably got a really good shot right now for medical school as well. But he just finished a master's and blah, blah, blah. But the pipeline idea is, and affirmative action, if I were to speak to my own story, there's a misperception that somehow affirmative action means going out and finding people of lesser quality or value and bringing them in and taking somebody else's spot who is of greater capacity and value.
Yeah, that's the critique.
That is completely erroneous. And it's also really quite hypocritical when you look at the legacy admissions, when you look at the money admissions, when you look at what happened with all of those high-level parents who bought spots for their kids at Ivy League schools and got tapped on the hand for that because money talks. I went to Georgetown. I'm very grateful. Laura Pendleton was a recruiter in the 70s. She rode around in her car around all the different boroughs of New York, packed her car with a whole bunch of us students, took us down to Georgetown to visit the school so we could even see what it was like and know. Now, I kind of knew because I had already had somebody, my neighbor down the street, who was there. And she was telling me this is a great school. She was studying nursing. And my neighbor across the street, who had studied there and became a linguist, fluent in 5 languages and a UN interpreter, etc. So I had my heart set on trying to learn more about it, if I could maybe go there. But that kind of reaching out to bring us in and let us feel the possibility and meet other students that look like us and encourage us was so phenomenal when that first started, because the other ones ahead of me who went there just really ended up by happenstance through guidance counselors who really believed in them and saw their brilliance, etc. However, when I got to Georgetown, having started college early, back in those days, they didn't have the whole high school college thing at the same time. We figured it out on our own. I finished high school early and had started college at 16 to take chemistry so I could finish on time, and graduated with a higher than average entering SAT score and a full scholarship with work study. My so-called advisor met with me, and the first thing he said to me, well, a lot of Black kids come here and think they want to be doctors, but then they change out because they can't handle the work. This is his opening line. The man that's to advise me.
There's the prejudice and presumption and bias right
out of the box. It's kind of like they were forced to start having us come, but they weren't exactly going to be friendly to us when we got there. And I, meanwhile, had read the entire academic manual and had laid out my entire 4-year school plan, but you had to have it approved by your advisor. And he was trying to outline a plan for me that would have spelled disaster because I also had to work. And it was not taking into account that I was a first-year student, that I had graduated high school early, blah, blah, blah. I actually placed out of English. But I said to him, show me in the book where it says I have to take these classes the way you're saying I should take these classes. And of course, he couldn't because it wasn't there. And he was trying to say, well, it shows your competitiveness. Well, it would have really set me up for failure, because I hadn't had calculus. I had only had pre-calculus as a high school student, and calculus was a requirement. So I left that meeting and decided I was never going back to speak to that man, who I learned later, meeting other people that came after me, told similar things to other people who then on still managed to somehow become doctors. I found a higher up, the one Black student who was a 3rd year, and I went to him. And he was kind of like our big brother. And there was also one Black medical student from Georgetown that would study in a place called the Black House, where we would all meet and we would all hang out and we would study. And I said, this is what I'm thinking. He's like, don't listen to that guy. He says that to everybody. First validating me was there something wrong with me? And I said, no, okay. And then I made my own plan. And as they say, the rest is history. But had I not found someone who was concerned about me to cultivate my sense of belonging. So affirmative action is about giving an opportunity. I needed a chance to get into that school, which wasn't happening for students like me at that time, such that even if you got in, you could still see the mindset once you got there of what was there.
Yeah.
You could be far superior, of which most of my classmates were, and yet still be treated as less than. And that's a pattern that continues to repeat itself throughout life. So you just have to be ready to be in a state of excellence, which is why I'm so happy I went to Howard. And why I've had a chance to work our pipeline program and identify students that I see that are talented and have potential, And it's not all Black students. I work with all different kinds of students. I was teaching at New College, which is under siege right now, and we have a huge pipeline there. Pretty much 90% of the students over the last 12 years that have gone into medical school, I advised while I was at New College. They're brilliant. And all of them were of other ethnicities other than Black. No, not all of them. Couple of Black kids, but most of them were white. And some LGBTQ and other, whatever, considered people underrepresentation. But it's all about identifying talent and encouraging that talent and knowing that highly talented students require a different type of encouragement because they're very hard on themselves. They tend to be perfectionistic. But they also often lack the kind of advisement that privileged students have, where they're from families that have graduated from college or have uncles and parents even who are doctors or other high-level professionals. A lot of my kids are first-time college graduates or the only ones in their field going into something scientific. And it's a real process to get internships, to do research, to understand how to request letters of recommendation, and to just build relationships, how to act, how to dress in certain, all of these things that I cultivate with my kids through example, but just taking them around with me to see how I am in different things and observe that interaction and also challenging them and pushing them. I push them very hard. Some don't like it.
Yeah. And one of the things, Dr. Randall Morgan, who's my co-host on this mini series that we're doing here at the NMA, his emphasis is so much at the Cobb Institute on it's all about mentoring. It's all about putting that mentoring in place. So you're familiarizing people and supporting people.
Yes. Well, we work together. I don't know if you know, but we used to share office together.
You're neighbors, right?
Yeah. Well, yeah, we're neighbors now. And with the Gulf Coast Medical Society, which I'm the secretary of in Sarasota, and he's the treasurer, and then the Multicultural Health Institute serves as the sort of clinical and recruitment arm to engage with the NMA doctors so that we all work together. And then we have the administrative infrastructure. So we set up the community events and identify the students. And then we have a shadowing program and we place them with the Gulf Coast Cobb Institute so that it's a win-win all the way around. And I think we've helped many, many young people and many, many community members. It's been very, very impactful, that type of model, such that we really hope to replicate that nationally. I've been working with different groups on how do you create community partnerships with NMA members, with fraternities, sororities, faith-based. That's our whole model with MHI. We build collaboratives and we bring different people together from their different areas of strength and resources and connectivity to best disseminate information, as well as to do screenings, as well as to provide services and link people to services and to improve care.
So if people are in other areas and they want to learn from your model and your success, how can they tap into that knowledge?
Just
call you up?
Call us up, www.the-mhi.org, or like our Multicultural Health Institute Facebook page. Look at any of our previous live streams. We have a YouTube channel. We are available for technical support, and we do advising and consulting, and we have helped on grant consulting. We just have a big one right now with environmental and climate awareness with FAMU to help to develop them as a data center and to improve monitoring and community health education around environmental justice issues. That's our real big push right now, because that's everything is the environment.
Wow. Well, we just have time to talk about environmental issues before we run out of time. So that was a beautiful segue. And that URL, that website once again?
www.the-mhi.org.
I'll put that link in the summary for our listeners.
Thank you.
So tell me about your concerns about the increasing problem with climate change, and what are you doing there in the MHI to work on this?
Yeah, so I am happy to provide that link to our environmental justice convening report. As I stated, we do assessment, and early on there was a concern of the environment, but we had little wherewithal to address it. There are significant environmental and climate issues in Southwest Florida and throughout the country due to historical environmental racism. Sarasota being an example. North Sarasota, which is an area where 70% of the Black community lives, is surrounded by a ring of environmental toxicity issues. There's a large, what's considered a brownfield of 80 years of illegal dumping, 12 feet deep, with heavy metals, mercury, lead, cadmium, et cetera, identified. Across the street from the Black High School is a concrete recycling factory and metal recycling factory and asphalt factory, the area general recycling factory with identified pollutants and large amounts of fine particulate matter, et cetera, et cetera. The environmental justice screening tools, we've been able to identify that it's at the 95th percentile for particulates in cancer, also very high in the 95th percentile for asthma. We have a huge disparity in asthma and respiratory conditions. So we were lucky enough to have an attorney that led suit successfully with a settlement for water pollution. And with those settlement funds, we held a year-long community convening and focus groups, as we've done previously, on what to do with those funds to help beautify a park area near a waterway. That's one of the many, unfortunately, affected waterways in Florida. And we're hoping to see that beautification through, as well as a citizens advisory board to maintain compliance with the settlement agreement so that the polluting can stop. And we've begun a youth ambassador science club for environmental awareness, as well as a nurture and nature veterans kayaking and environmental awareness group to create sustainable embedded things within the community that will perpetuate into time to increase awareness and understanding of the impact of the environment on health. We know that environmental toxicity is related to neurological conditions, behavioral conditions, immune dysfunction, as well as respiratory and dermatological conditions, and even diabetes, which ties into some of these disparities that we're dealing with. The whole idea of heat and heat exposure, which has been extremely challenging as the whole world is the hottest it's ever been right now, and education on how to properly safeguard and prepare. We have every summer kids falling out, passing out, unfortunately, even heart attacks. A lot of that is related to dehydration, inadequate shade and cooling down and things like that. So we're working on how do we create cooling stations? How do we create awareness of understanding for people who have to work outdoors, changing work hours, wearing hats, sunscreen, creating shade structures and things like that for protection from the heat and the climate.
I mean, isn't it so infuriating every time you hear a politician say, every time it snows, they say, well, there's no such thing as global warming, right? But what you're doing is you're really building a framework for civic society
Right.
around this issue
Right.
locally.
Yes.
And you're tying that to recreation with kayaking.
Yes.
So this is civic society, this is healthy recreation. It's a very virtuous circle you've been able to establish.
Beautifully. And at our convening, we summarized all of the findings from the interactions over the year. And we also had Rob Billot of the movie Dark Waters, which was a true story of his 20-year fight to bring justice regarding the polluting of DuPont in West Virginia and how the world knows about forever chemicals now, PFAS and PFAS, that are 98% of the world's population and are tied to any number of immunological and malignant and other conditions. So understanding the sources of that, understanding how do we begin to test for that. And he really encouraged us in our work, which I took to heart, that this is where it begins. It begins with community. And one of the biggest things they asked for at the convening from the community was more education to understand where are we at. And we're going to get more monitoring. We're going to get more general sense of awareness. What are some of the things that can be done? We have a whole list of recommendations. We have an EJ Climate Cruise presentation to philanthropic organizations on the kind of things we think they might want to start funding to help support organizations that want to continue to work together to deal with this. So full circle, Sankofa, full circle.
Wonderful. Well, Dr. Lisa Merritt, thank you so much for joining us this morning for this episode of the podcast. It's been informative. It's been inspiring. I've learned a lot. Thank you so much.
You're most welcome. Thank you for having me, and God bless you for your work.